Hello everybody, welcome back to another video. Today we're going over the labral repair of the hip. And so today we have a different sort of video. It's my honor to have my classmates present this with me. And we're going to talk about what the hip labrum is, how it's repaired surgically, and the recovery process and what that looks like. Before we get into the presentation, I just wanted to show you all the hip labrum. This is a fibrocartilaginous ring surrounding the femoral head. It comes around and surrounds the entire acetabulum to hold the femoral head inside of the hip joint and to provide stability. And it can get torn in some cases, and that's where we come in today. So without further ado, we will get into our presentation.
All right, so like Dylan touched on, the labrum, it kind of deepens that socket, similar to the shoulder joint. So we call this the acetabulum instead of the glenoid. So the prevalence in these hip labral tears, so they're pretty common, cause of groin pain and some other limitations. There's a reported rate of 22 to 55% in athletes, and then it can be almost up to around 70% in people with mechanical hip pain. The most common things that will cause it are acetabular hip dysplasia, and then females that are active, but it can also happen in any age group. Some of the symptoms, you can get referred pain like dull or sharp. It usually is like deep in that groin or like medial thigh area. And then you can get some mechanical symptoms like catching, clicking, crepitus, things like that. And then pain with weight bearing. Some of the related injuries and risk factors. So there's two types of mechanisms of injury. You got atraumatic and then traumatic. Atraumatic, just like it sounds, no trauma. It's gonna be repetitive motions and overuse, especially in those like extreme ranges. So the most common way you can injure it would be external rotation with hyperextension. And then you've also got traumatic, so like your classic dislocations, subluxations, some of those high impact contact sports like hockey and football. And then some more of the risk factors like we just talked about in the last slide. So you got the acetabular dysplasia. There's also femoral acetabular impingement syndrome, which has two types, the cam and the pincer. And you can see pictures of those on the left. So the cam is going to be more about that femoral head and neck junction, having some abnormal bone growth. And then the pincer is more about the acetabula itself having that like kind of over coverage of the roof. And then there's a few more risk factors listed down at the bottom: capsule laxity, some more impingement of the iliopsoas tendon, and then it can also occur with chondral lesions, which are those loose bodies kind of on that articular cartilage of the joint.
So now that we kind of covered what the actual labral tear is, what are the indications and contraindications for actual repair surgically? So I have here listed the indications here. So a lot of it is if you have pain for more than 6 months, if you take an X-ray and you have evidence of the femoral acetabular impingement, it could be either cam or pincer. And then also the big one is failure of conservative treatment, whether it be physical therapy, medication, and if that fails, then it would be indicative to actually perform surgery. And then some contraindications, a lot of this is severe articular damage. So if that labrum is really, really ripped off of the socket, or it has intrasubstance degeneration or calcification going on because of damage, that could actually be a contraindication for a repair. I have listed it here on the right. Typically they'll do a repair if it is indicated. If it's contraindicated, they can do a labral reconstruction where they take a part of tissue from another part of the body, like the IT band, and actually form a new labrum. If that doesn't work, and eventually you go into the actual total hip arthroplasty or a hip replacement. So how is the surgery done? So step one, they usually typically apply traction or a pulling force on the femur to create joint space in there so they can work there. They make a small incision in the groin area. You can see over here you have three kind of points of cutting that they go and enter into the socket. And then they enter arthroscopes, or little camera ports basically, typically three of them, and they can transfer the arthroscope or the camera between these three to actually look and visualize the different parts of the joint. And then they'll go in with a little drill saw and they'll shave away any cam or pincer extra bony growth either on the acetabulum or the head of the femur to fix those problems in the FAI patients. After that, if the labrum, again, we're going in to fix the labrum, so you need to actually reattach it to the actual acetabular rim. So they'll drill anchors into the actual acetabulum. After that, they'll tie sutures from the anchors around the labrum to create that suction and compressive force back on the acetabulum. And then after they tie it all up and it's right there, now we just need to let it heal. So they release the traction on the femur. They remove all their instruments. The capsule's closed and the incisions are all stitched closed. So outcomes. So a lot of the outcomes, I'll actually show you guys the modified hip Harris score here. I have it pulled up. And this right here is a outcome measure that they give patients, and they rank their limitations with these following activities. So, for instance, pain. Do they have a limp with their walking? Do they need support like crutches or canes? How long do they walk for? How do they have trouble with stairs, putting on socks and shoes, sitting in a high chair, any chair? And then do they use public transportation? The higher the score in the modified hip Harris score is better. And so it would indicate a better recovery. And so a lot of the systematic reviews that I found indicated that I like this point here. So average modified hip Harris score pre-op or before the surgery was around 58 to 66. And then after the surgery, the hip Harris score increased all the way up to 80 to 89 after 5 years, which is fantastic. So it is a really good and it's associated with decreased pain in the hip, which is fantastic as well. Post-op complication rates, there are some. The systematic review did reveal that conversion to the actual hip replacement is from 0 to 27%. Overall secondary revision rates, so them going back in to fix something, was about 0 to 36%. General things to keep in mind during the surgery is keeping the hip traction time below 2 hours to reduce the risk of nerve injury. Excess traction on the nerve can result in the injury there. And then, of course, as always, with any surgery, there's a risk of infection, nerve damage. So just keeping that in mind. But overall, it's a pretty good outcome and prognosis for this surgery.
Okay, so getting into our protocol, so this is kind of the recipe we follow after a surgery. We have chosen one from Ohio State. So early on, this is phase 1. It's within that 0 to 4 week range. Our goals during this time are to initiate PT early. We want to get people moving pretty quickly. And then protecting healing tissue. Obviously, you've just gone through a surgical repair. You want to let the tissues around it heal. And we're trying to reduce pain throughout this phase as well. So our precautions involve no sitting for a prolonged period of time, no excessive hip motion, so no extension, no excessive external rotation. We want to do partial weight bearing for the first 2 weeks, so that's keeping part of your weight off of that one leg. Avoiding any twisting and pivoting, anything that can create shear onto the labrum. And then obviously trying to avoid pain as much as possible. Our contraindications, there are none listed in this particular protocol, but kind of refer to those precautions to guide your treatment. For our testing measures, we want to do range of motion, looking at strength, any edema that might have accumulated, and then we can do more functional stuff like functional gait analysis, postural assessment, and that good stuff. Continue with our phase 1. This will kind of go into affecting daily activities, so prolonged sitting might be an issue, independent walking, sitting and standing transfers due to the pivoting and twisting aspect, difficulty with general activities of daily living. Our outcome measures we can use to kind of quantify within the early phases are single leg stance. This is good for kind of initiating that weight bearing back, so we can use that as a measure. 10-meter walk test, the tug, VAS pain scale, and patient-specific functional scale. To move on to phase 2, we want to be able to have a normalized gait pattern, and then minimal pain, so we kind of control that aggravated phase. Interventions during this time, we want to do range of motion. Again, we're working to get that motion back. So using active range of motion or an upright bike to help with that. Neuromuscular control is super important to get before we start working on strength. So really working on stuff like glute sets, quad sets, anything to kind of activate the muscles. Strength, we can do active heel slides, working on the hip flexor strength. Standing TKE to kind of just get general weight bearing, closed chain exercise back into the body. Arch progression, we are working between weeks 2 to 4. So you're going to be on crutches immediately, that's part of the partial weight bearing on that leg. So you want to work to wean off the crutches. So as soon as you're able to have a 30-second single leg stance without compensation and then a normalized gait pattern, that's kind of your markers to use to actually stop using crutches. Our phase 2, now we move into kind of restoring full range of motion, both passively and actively. We want to get the strength back to as best we can, normalizing posture, getting that normalized gait back after decreased use of crutches, and then tolerating ADLs again without pain or limitation. Precautions here, avoiding any joint or soft tissue aggravation due to early or too much progression in the activity. We don't want to do any excessive stretching at this point either, and then definitely no running or impact. And then same as phase 1, we don't have any contraindications, just refer back to precautions. Our testing measures also will be the same as in phase 1. We can use range of motion, strength, edema assessment, and then functional assessments as well. Outcome measures, also the same. We're still trying to just use the information from phase 1 and kind of just work into phase 2 to see how we're progressing. ICF impacts, so kind of those more functional impacts will be difficulty with stairs, that more running and ability to exercise, and then still some difficulty with ADLs since everything has not normalized. To advance to phase 3, We want to have symmetrical and pain-free hip range of motion. We want to have more strength seen by ability to step down, and then again, kind of that normalized gait pattern and pain-free ambulation to be able to integrate back to the community. And our interventions here, we're still working on range of motion, still working on neuromuscular control. Strength, you can progress a little more in this phase, and then now we're adding in cardiovascular exercise using both the upright bike and the elliptical once that there is pain tolerance to this.
Okay, guys, hello. We've made it to phase 3. We've normalized gait. We're getting through range of motion. It's looking awesome. So what's the next part, right? So we want pain-free. That's the name of this goal, pretty much. We want to try to normalize motion, normalize motor control within their movements without that pain and without that pinch feeling, as you can see in the goals. And that's just really important. And also we want to really normalize the strength of the hip so that now that we have kind of like that range of motion back, we're getting back to walking and moving, we want to start initiating strength without sacrificing range of motion. So in this phase, it says we want to avoid excessive stretching. So you kind of want to maintain whatever range of motion you have without pushing it too far, and then make sure you're not losing it over time. So it's important to still measure range of motion. And then a big part of this in terms of testing measures is start using handheld dynamometry. We'll talk a little bit about that later, but essentially in this goal, you want to reach 80% of the unaffected leg in terms of all hip movements and strength, and at the knee as well. And then also, once we're getting down later, phase 3 is it can be malleable in the sense that depending on how well that your patient's progressing and their goals, you can start initiating things like plyometric or return to sports in this phase very cautiously. And in this phase, you're really going to want to focus on an analysis of the biomechanics as you see in the tested measures. So just making sure there's no compensatory motions, not making sure there's not too much knee varus or valgus or excessive motion at the hip. All of those are really important for this section. Okay, so ICF impacts. We're starting cardiovascular exercise, but we want to be very cautious. If they're feeling any pain or any pinch feelings, we want to at least minimum 1 day of rest between sessions. And if that is consistently happening, we want to reanalyze what's going on at their hip or their knee and just make sure that we're not re-injuring or re-causing any things to happen at their surgical site, anything like that. We also want to check for edema, and then as well as they're just going to have a hard time getting back into cardiovascular stuff as well. For outcome measures, it's essentially the same. What we can add is something like the Trendelenburg special test. And for criteria for advancement, there is no specific criteria. It depends on the patient, and it also depends on their goal. If they have a very physically demanding job or a sport that they want to return to, we end up going to phase 4. Or if you think that there's a little bit more that they can get out of therapy, that's when we're moving on to phase 4. So to finish off phase 3, here are some interventions for range of motion. We still have like some similar stuff that we had before. Now it's a lot more active, as you can see, for range of motion. For neuromuscular control, we're going to start off with the shuttle. The shuttle is a great way to implement plyometrics without having full body weight support. So you can do double leg and then switch to single leg and focus on the patient having symmetrical landing and also just focusing on how that feels again to administer plyometrics. Once you feel that they have that kind of sense of movement again, they're getting back into it, an agility ladder can be great in this part of the area, and then just slowly working up to using both legs again symmetrically. And then lastly, jumping with the mirror in front of you once you progress to that, and just analyzing the biomechanics and focusing on takeoff and landing is great in this scenario. Next, for strength, as we are doing a return to running protocol and things like returning to sport, the Cumberford hip series, including things like clamshells, reverse clamshells, raised clamshells, and side-lying hip abductions, are awesome for this portion. And then you can also add weights as seen fit. And then the leg press is also going to be your best friend here. Your goal for phase 3 is to do a double leg 150% body weight, and you can progress that as you see fit over the course of your various sessions with the patient. And then lastly, for cardiovascular progression, a dynamic warm-up like the agility ladder is great. And then also we're still progressing that cycling and that swimming, just trying to increase the resistance on that. And then you can also, in swimming, progress to freestyle kicking, but still avoid rotational kicking. Okay, lastly we have phase 4, which is the return to sport and full activity. As we said, this is kind of like depending on what the patient wants and what they need. If they have a very physically demanding job or a sport that they really want to return to, that's when you can slowly start incorporating some of the motions associated with that sport into your therapy plan, and just making sure that it's safe and focusing on neuromuscular control. Again, it's always quality over quantity. So precautions, there's an emphasis on the landing mechanics, of course, takeoff and landing. And then if increased pain and plyometrics, we tone that back, focus on neuromuscular control, strengthening, all that kind of stuff. And then you just want to closely monitor. And then contraindications, speed training cannot be implemented until the entire return to run protocol is completed. And that's very important. So just make sure that you cover all your bases on that before you start any speed or power training in that sense. Tested measures, all the same. For the handheld dynamometry, we go to 90% compared to uninvolved hip and knee. Next, ICF impacts, just returning to sport or demanding job. And then for outcome measurements, we have the Vail Sports Test, which is a series of various criteria that can be met. It's in the appendix of the Ohio State protocol. And then stuff like the Y balance test, things like that are great for this scenario. And then, as you see right here on the right, there's a set of criteria for return to sport that have to be met if the patient does want to return to said sport. Lastly, we have some interventions. It's just continuing the agility ladder. You can add some Y balance, some Bosu ball drills if you think that's relevant to the patient's sport or return to work. Single leg squat or leg press, 100% of body weight is the eventual goal here. Obviously, that's kind of like a single leg stance, just progressing that to what we would consider back to a good level of function.
All right, here we got an infographic. Kind of goes over all the information we talked about, and it kind of puts all the information in a more organized fashion, and something you kind of reference back on about hip labral repair. It kind of goes over background, mechanism of injury, surgical procedure, and overall the protocol. And then these are the references.
Thank you guys for watching. I hope you learned something. I hope you took something away from this. Thank you to all my classmates who helped me put this together. And I am the PT guy, educating you on God's wonderful creations. I'll see you in the next one.